My name is Elizabeth Markey. I am the patient educator for the Center for Restorative Breast Surgery. I actually began with this practice 12 years ago. I was working for one of our breast surgical oncologists that's actually with our practice too, for 19 years, treating women for breast cancer, assisting Dr. Stoyer to treat the women, in surgery and working also in the office and providing coordination of care as an office person too. And decided that I needed a more positive take on women that have breast cancer. I did like what I was doing, but I felt like maybe a little bit of a change in kind of the same area would be, a positive change for me. And so we have worked with the reconstructive surgeons, with Dr. Sullivan and Delacroix, for many years, and I actually joined them in 2004 and began doing the patient education shortly after. Well, I'm part of the intake process. When a woman calls our practice, either if she's newly diagnosed with breast cancer or a woman that might have already had surgery and is calling now to begin her reconstruction, I speak with her. I first go over the forms of reconstruction that we do and tell her a bit about the autologous tissue reconstruction that we primarily focus on, and walk them through that process, telling them what we do in stage 1 and stage 2 of the surgery, what to expect, all of the information as far as recovery time, and to answer any questions that they might have about that. And I take a screening history on them that helps us to determine what they're a good candidate for, which form of reconstruction, which flap surgery, and also to make sure that oncologically they are a candidate for reconstruction. More advanced disease, when patients, on occasion I do receive contacts about patients that may have stage 4 breast cancer, and they are requiring long-term treatment, and I still discuss each case with our reconstructive surgeon and the breast surgical oncologist, and they make the decision whether or not perhaps something temporary can be done first, to place a temporary implant there and to let them complete their treatment, and then to return to have tissue placed there. Or, they do give me the recommendations as to what should be appropriate for them. We get many calls. A good part of our practice is women that have been treated elsewhere and have had reconstruction, and their reconstruction may have failed. They may have had a tissue flap done, and the tissue did not take, the flap did not take, so they have no reconstruction. Or in most cases, there are women that contact us that have had anywhere from 7 to, sometimes I recently had a lady in her who had had over 20 reconstructive surgeries to try to repair what was done. And it's a variety of surgeries, whether it's not only tissue reconstruction but mostly implant reconstruction, and they've had issues with infections and the implants actually extruding, coming out of the area, out of the pocket and such. And so they've gone through a lot, and at that point some of them are very, of course, emotional about it, and are really looking for a solution to be able to go back to having a a normal life again for themselves so that they can be active and do all of the things that they used to do. It really does affect their life quite a bit. And so the way that we handle those is I actually ask the patients to, if they would mind, we have a secure site, they send photos to me. I take their history and know what they've had already and surgery-wise, and ask them to send their records. They're more than willing to do so, because if there is going to be a solution for them, they want to do everything they can to get to that place. So I review them with the surgeons, one of the surgeons, and they make their recommendations. And I call the patient and explain that to them. And quite often, too, we offer for the surgeon that reviewed the pictures to call the patient. I think that helps a great deal, too. It makes them feel better, especially for ones that have been through so many reconstructive surgeries that have not been successful. You know, they're not looking for perfection. They just want, in some cases, to have symmetry and have actually a breast or a form of a breast that they can put in a bra and not be concerned whether or not someone notices, or to make them feel restored and whole again. And there are women that have gone through countless things to try to attempt to fix and repair things, but without success. Well, when you choose to do the autologous tissue flap, there are two surgeries involved with it, a first stage and a second stage. The first stage is actually the removal of the breast and then creating and restoring the breast with that tissue that you take from either your abdomen or your gluteal area. The second stage is focused more on aesthetics. You know, we create like nipple structures, do any revision work, do some aesthetic work to make smooth out areas and to make sure the breasts are matching and symmetrical. So it's usually two surgeries only. In implant reconstruction, there is one surgery usually when you are doing, you know, a mastectomy and then placing an implant. And then we sometimes 3 months later or so, we make sure that everything is symmetrical, and do we need to make any adjustments on implant sizes or anything like that. But most often that ends the process also. Actually, we reassure them, because that is probably a very common question and fear that they have. How am I going to leave my home state and home and out of my comfort zone to have surgery? But I do explain to them that they are here for 10 days. I walk them through that process. I also reassure them that when they do leave us and travel home, we stay in touch with the ladies by calling them. Our physician's assistant calls them once a week to help them through the recovery process and to assist in anything that they may need. If they have a question about an incision or the way something feels or anything, we're there to assist them with that by, you know, giving them recommendations as to what to do if there's anything that needs to be done. And so that reassurance, I think they feel much better about knowing that we're not going to just let them leave us and let them go. We don't, until we can take them through the complete stages of the surgery and make sure that they are restored and completely finished. We have a travel coordinator that assists with, once I give them a surgery date and they know their parameters of when they need to be here and when they can leave, then they do stay in one of our local hotels. We have many of them that we have contracted rates with, and the travel coordinator, Heidi, assists with that and sets that, makes the reservation for them. She assists in helping them know what they may be looking for to stay. There's also another facility that they may stay, the Hope Lodge, that's an American Cancer Society facility for ladies that are more of on a budget, that maybe can't afford, a hotel. They're actually are here in the hospital. Once they have their surgery, their stay is 3 nights, and on the 4th day, they leave the hospital, and then they go to a local hotel or the Hope Lodge facility. They see us on the 7th day following surgery for a post-op visit, and they're free to travel home on the 8th day. So altogether, it's 10 days that they are here total time. But I'm counting also the time from when they arrive, and they're here a couple of days prior to their surgery date, because we have some appointments we need to accomplish the day before their surgery. Actually, no, we do not require that they have a physician at home that can assist them with their post-op care. We, again, like I said, we stay in touch with them and assist them with anything that they might need. But patients do quite often ask that, do you require that I have a doctor at home? No, but if you have one that is willing to help you and to see you if you need to be seen. Sometimes ladies do have that established relationship with their oncologist or their breast surgeon that may have done maybe a previous procedure on them, and they're willing to assist them with any drain removals or to just see them post-op. We communicate with their office and make sure, open the rapport between us and that office, and assist with anything, send records, operative notes and such of what we've done, and just speak to that. Our physician's assistant speaks to the doctor or one of our surgeons. No, actually, I only work with all the clinical aspects of their journey. We have a insurance benefits assistant who, once I complete my intake form, my screening form, and go over the education part of the procedure, then we do have someone who checks their benefits, and in our insurance and billing office. She calls them directly and discusses their benefits with them on how they apply to both the surgeons and the hospital, answer any questions that they might have about the financial aspect of the procedure, and then their contact with any questions that they might have financially. I discussed actually with the ladies that are needing a mastectomy, what is a nipple areolar skin sparing mastectomy, whether or not they are a candidate for it. I definitely tell them what is involved in that, because most of us think of a mastectomy with the removal of all of the skin, nipple and areolar and breast tissue. Well, this is it's a bit different, the approach to it. So to have them understand that, and to also then go over the type of reconstruction that they're a candidate for, whether we're going to use their tissue from their abdomen or their gluteal area, and what's involved with that. So just go over each part of the surgery that's being done by the surgical oncologist and the reconstructive surgeon. I would say no, not at this point now. Over the years, it's changed quite a bit. I think because there is so much information as far as for like breast cancer, what's appropriate, what is a sentinel node biopsy, most of them are aware of what the cancer procedure is. As far as the reconstructive surgery, a lot of them have done quite a bit of research too, so they are aware of what a deep flap is, a gap flap, but walking them through the process and letting them know every detail about it does assist them, I think, in making them feel less anxious about it too. When they contact me about, because they maybe have a strong family history, or if they have a genetic mutation, they certainly have seen their local genetic counselor and surgeon with their recommendations, and so they are quite educated and they know what their choices are. But what we do is just go over again with them what nipple reel or skin sparing mastectomy, the procedure, what it entails. And, we do discuss too that doing this preventatively and prophylactically is not going to make their risk zero, that they're going to, that there's no chance that they'll ever develop a cancer, but it certainly does reduce their risk dramatically. And we review that. And, I would say that most of them have already made their decision that they want to have the surgical preventative mastectomies instead of surveillance. And so we review all of that information. Quite often there are women too that who are diagnosed with breast cancer and have a family history, and they have not been offered genetic testing locally. So we do make sure that we capture those too, to let them be aware that they are eligible for genetic testing and, what they can learn from it. And our breast surgical oncologist sees them, of course, when they come in or are seen, and discusses that with them. To make sure that they are, educated to know what, and to receive all of their options. It's very important. All of, not only their oncological options, but also their reconstructive options. We have found that often women have not been given all of the information to be able to make a good decision or appropriate decision for themselves. A lot of times I hear, well, if I would have known about this procedure, how I wish I would have known, I would have made this decision from the beginning. I wouldn't be in the situation that I'm in. No one told me. Or I was in such a, just anxious and nervous about the cancer diagnosis that I very quickly went ahead and had my breast removed without even worrying about reconstruction. And I wish I wouldn't have done that. I wish someone would have told me. So a lot of times we do recommend, I say, think about, the different procedures that we've discussed. You need to make the decision that's appropriate for you. And I try to reassure them as much as I can. And also, definitely too, to let them speak to one of our surgeons also, because that also helps to make, I think it reassures them and makes them feel more secure too. I think now within the last 5 years or so, I've seen more and more offices that we may receive referrals from, other cancer centers that we receive referrals from. I now see patient navigators, or educators now as part of their practice. 12 years ago when I first started with this practice, no, I didn't see that so much, and wasn't really aware too of what one, as the role of an educator, what she would do. But part of my role with the surgical oncologist was to review the oncological piece of it and what surgeries Dr. Stoya had recommended so I was already familiar with that. And because we referred our patients for reconstruction and made sure that they saw a reconstructive surgeon and had that choice, I had a lot to learn, of course, but, you know, it was quite different when I first began with them that there was a role for an educator. It's to help coordinate their care and to help them make the best decision for them too, and to get all of their information and get all of their questions answered so that they feel a bit more comfortable with, you know, having their surgery with us and the decision they made. You know, it's important, definitely is important. I hear ladies cry quite often from having so many surgeries, reconstructive surgeries, or, you know, that they've gone through, and just how unhappy they are about that entire process, and they wish they would have had somebody to help them, guide them along the way. For women that have had or have a lumpectomy, they choose to do the breast saving operation. And of course, when you do choose that operation, there's always radiation therapy that's given after that. Women we see may have quite an asymmetry in their breast. The radiation, along with, of course, the surgical removal of the tissue, their breast may be quite a bit of difference in size. And so we're contacted from women that have experienced that, and that they're looking for something that would even them, you know, out and give them symmetry again. Women often say to me, you know, one breast is a D cup and the one that had the lumpectomy is a B. So I have to place something in my bra and wear something in it to even me out. So we do review everything and go over with them that they can have tissue added to that breast. They have the option to do so. We can take a flap of tissue and place it actually in that breast and position it, and of course give them the same amount of volume that they have on the unaffected side. We also offer them too that if they want to, some ladies really do want to reduce the larger breast and make it the same size as the lumpectomy, the breast that's had the lumpectomy. So we offer to do that also and to give them symmetry that way. In the women that we add flaps to their breast that have had lumpectomies, we make sure that they understand too, they have a current mammogram beforehand that shows absolutely no evidence of disease, you know, and then when we add the tissue there, we also explain to them that they have to start again with a new baseline in that breast, and to make sure that their mammographer knows that they had tissue added to that breast. We also offer to, when women have such a great asymmetry in their breast size, we'll offer to have the remaining tissue that's left after the lumpectomy, to have that removed, to do a skin sparing mastectomy, to just go in and remove the remaining tissue and then replace that entire breast with a tissue flap. We also perform that too. So they have, you know, several different options, and all are discussed with them to help them decide what might be best for them. The issue with trying to place an implant, having a completion mastectomy or the removal of the remaining tissue and placing an implant there, it's trying to place an implant in a radiated field. That's a lot of the ladies that we see have had that form of breast reconstruction when they've had radiation, that have had numerous procedures done. It's just not a good choice always to place an implant there. So the recommendations are to either add tissue or to reduce and make the patient symmetrical. Sometimes it's just a matter of releasing the tissue or the scarred tissue, or maybe that they may have developed in the lumpectomy breast, and to release all of that skin-wise and to make sure there's not anything that we need to do. Sometimes it's a little lift, too, that we need to do on that side and to reduce the unaffected breast so that they have symmetry. Well, we do speak to women because as far as trying to restore that side and to make them symmetrical, trying to do it with an exchange of an implant. You can sometimes do that, of course, and see if there's no issues that develop from it, like capsular contraction or anything, following because you've had that breast radiated. We also offer to place tissue there, to take out the implant and to place the tissue there to give them symmetry.
This presentation is made possible through the support of Air Expanders and the Center for Restorative Breast Surgery in New Orleans. For more information, go to I'mTakingCharge.com.